Good afternoon, good evening to everyone. Thank you. First, I want to thank the local organizers for giving me this opportunity to speak on the complications in pediatric surgical oncology. All right, so I have no disclosures, and we'll go through the definitions, the classifications of complications, management of complications, and how some of those we can prevent them. So firstly, a complication, well, when we have an event that is part of a surgical strategy, then we do not call it a complication. Just like in this slide over here, this is stage 4 neuroblastoma with invasion into the kidney. Despite chemotherapy, there's no shrinkage of the tumor. So pre-surgery, we decided that the nephrectomy will be done together with the resection of the tumor. All right, so another example is a cervical thoracic neuroblastoma, and after surgery, we get a Horner syndrome. And some of us can argue whether it is or it is not a complication, but it is an expected event. So these complications can be expected or unexpected. They can be avoidable, and some can be unavoidable. And for the children that we deal with, because they have cancers, they are immunocompromised hosts, we have to balance between the risks of complications and the success of surgical treatment. And the surgeon should have the ability to manage such complications during or after surgery. Once we have such complications, we should learn how to improve. These complications would help us improve the understanding of technical challenges, improve the quality of surgery, as well as our strategy. And like in 2005, Giovanni Cerchetto, in his paper on surgical risk factors association with complications, as you can see here in his tabulation, that patients who have had incomplete surgeries tend to have a higher risk of complications. And for patients who have surgical risk factors, they have 17.4% chance of developing post-operative complications compared to those who had no surgical risk factors, only 5% develop post-operative complications. And from that came the development of the INRG staging system, where 20 such IDRFs were identified, and these image-defined risk factors were identified at imaging. These are not contraindications for surgery, but it allows us to consider other forms of treatments because they are associated with surgical risk and complications. All right. So, I think Steve Warman has also published on surgical complications, and he pulled out the classification of surgical complications as proposed by Dindo and Clavian. And this is how we can grade the complications. There are some more minor ones like grade 1, defined here, whereby they deviate from the normal post-operative course without need for interventions. And some of them may require certain pharmacological treatment with drugs, for example, like hypoalbuminemia, anemia needing blood transfusion, hypotension, hypertension, etc. All right. So, but grade 3s and above are the ones that we probably will be more interested in when we present papers, when we make recommendations. And these are the ones that require surgical, endoscopic, or radiological interventions and includes pleural effusions, chylous ascites, biliary obstruction or leakages, hemorrhage, intestinal obstructions. Grade 4 are the ones that are life-threatening and may require, they may be associated with single organ dysfunction or multi-organ dysfunction. And grade 5 certainly is the death of the patient. Now, next we look at a list of complications that I'll share with you. We look at the extent and the implications of these complications, how it's going to affect the patient's treatment, its management, as well as the prevention of such complications. Firstly, I'll deal with vascular system hemorrhage. They can be divided into intraoperative hemorrhages like ruptured aorta, vena cava, or intratumoral or a tumor bleed. Post-operatively, the patient could have a coagulopathy, primary hemorrhage, or secondary hemorrhage. And this is a 3-year-old child presented with abdominal distension and anemia. And you can see that on the scan, it is actually a ruptured tumor, ruptured neuroblastoma. And nowadays, we advise not to go in and remove this tumor, and especially if we can recognize the clinical features, probably preoperative chemotherapy will allow us to enable the patient to have a smaller tumor to deal with when we operate on them. This is a 2-year-old girl, a stage 3 neuroblastoma. After 6 cycles of chemotherapy, there was no reduction in size of the tumor. The tumor was encasing major blood vessels like the aorta, the IVC, and after surgery, there was actually, during surgery, there was the aorta was cut and there was massive hemorrhage. So this is one of the situations whereby we did a primary repair of the aorta. There are also instances whereby instead of a primary repair, we go on to do a graft. We can do a tube graft or an onlay graft, as demonstrated in this paper. And in other tumors, Sajid Qureshi has shared with us that, for example, like a retroperitoneal germ cell tumor, these tumors are associated with extensive vascular dissection, blood loss, and perhaps sometimes even a vascular repair. I have this 13-year-old male who had an anterior mediastinum tumor after chemotherapy. Well, it's a malignant germ cell tumor. After chemotherapy, he responded with normalization of HCG. During surgery, we did a resection of the SVC and put on an onlay pericardial graft. And there are also patients who have primary hemorrhage. There's a 4-year-old girl, stage 4 neuroblastoma. After chemotherapy, went in for the surgery. At the end of the surgery, everything looked very dry, but within a few hours in the ward, she developed hemorrhage, blood draining from the tube. And we went in, it was just a small arterial bleed at the diaphragm. All right, next is a secondary hemorrhage, duodenal ulcer bleeding. And this boy had surgical resection of the tumor. And then on day 5, developed hematemesis, fresh melena, and hypotension. And we went in and oversaw this bleeding ulcer. And this is another patient, a 3-year-old girl who had neuroblastoma, had surgery, post-operatively developed a biliary fistula, and subsequently 2 weeks later developed secondary hemorrhage, massive secondary hemorrhage. Next, we go on to chylous fistula. Some time ago, I wrote a paper on this, and the treatment we can actually use MCT diet, PTPN, octreotide chemotherapy. We can still continue with chemotherapy, and sometimes in such situations we have to perform surgery to stop the chylous fistula. Sajid, some years back again, reported that he managed all his patients conservatively, and they could all go on to continue receiving their chemotherapy. Right. So, and this is my paper on what I did. I'm currently doing at the end of my surgery. I look for the lymphatic channels and I try to oversew them before I close the abdomen. Renal system. Loss of function like a nephrectomy, as in the first case that I presented earlier on, or some of them develop atrophy, ischemia, urethric obstruction after surgery, or some urinary leak. All right. So these are 2 patients whom I operated on for neuroblastoma, tried to preserve the kidneys. I think the top patient actually, the kidney actually shrunken much more to probably leaving about 10 to 20% of renal parenchyma. And the patient at the bottom, the kidney just disappeared after 6 months in the PET CT. This is a patient with embryonic rhabdomyosarcoma of the pelvis. During the surgery, noticed that there was hydronephrosis. I put in a DJ stent and subsequently removed the DJ stent, and 4 months later, he developed recurrent hydronephrosis from a distal ureteric obstruction. And this patient had bilateral Wilms tumor, nephron-sparing surgery. On the left side, she developed a renal leak. She had a ureteric stent, but still after that, we actually placed a perinephric drain, and that helped solve the problem. And respiratory system, there are various different types of complications we can encounter: pleural effusion, phrenic nerve palsy, pneumonia and effusions. This is a patient who had a big, massive left upper zone mediastinal neuroblastoma. Okay, so after removing it, she developed bronchomalacia and needed a CPAP to open it up. And this is another patient who had multiple nodules in the lungs from relapsed osteosarcoma. So I performed metastectomies on both sides, but post-operatively, she developed ARDS and stayed in the ICU for like 10 to 12 days before she got up. Intestinal obstruction, quite commonly seen also in abdominal laparotomies. And intersubception as well. And this patient had a left kidney clear cell sarcoma, and at fourth post-operative day developed persistent vomiting. Right. So these are the pancreatitis, pancreatic fistula, bile duct obstruction. And this is a 10-year-old boy who had neuroblastoma. Large tumor, performed a distal pancreatectomy because of his involvement, and post-operatively he developed a pancreatic leak, and we did a percutaneous drainage, and then subsequently it healed. This is a patient who developed biliary stenosis, and we got the interventional radiologist to put in a biliary stent. Lastly, we will deal with neurological dysfunctions. They can be paralysis from brachial plexus injury, Horner syndrome. Then this is a girl who had lower mediastinal neuroblastoma infiltrating the costovertebral junction between T9 and T12. At the end of the surgery, we cleared the tumor, but unfortunately, 2 days later, we noticed that she developed spinal cord ischemia. And subsequently she could not walk. Right. And lastly, another cervical thoracic tumor. This child developed Klumpke's palsy soon after his surgery. And in conclusion, despite our best efforts, I think cancer surgery is associated with surgical complications with grave consequences. We hope to be able to learn to recognize the surgical risk factors, take precautions. If possible, we use preoperative chemotherapy to facilitate a safer surgery. And I believe experience leads to better management. And in such a forum, we should share some of this information to shorten our learning curve. And lastly, thank you for this opportunity, and I would like to invite you to come to Honolulu, and we're still not sure whether we will have a presential meeting, but we are now planning the IPSO 2021 in Honolulu. I thank you for your attention.